Good afternoon, and thank you so much for joining us. My name is Michelle Knighton, and I'm the Health IT Test Lab Manager at ICSA Labs. And I'm joined today by my colleague Kevin Brown, who is our Certification Body Manager. Today we're going to be focusing on the system design and application access criteria. So that would be criteria G3 through 5 and G7 through 9. Before we get started, just a few housekeeping items. First, please mute yourself. We are recording this session, and we hope to have it posted online by next week, along with the slide deck. We'll also send out an email notification to all registrants to advise when these are available. If you do have questions throughout today's session, please submit those using the chat feature in WebEx. Today I'm going to kick off the session with providing just a brief background about ICSA Labs and the criteria we're going to be talking about today. Next, Kevin's going to provide an overview of the testing requirements and some clarifications around G3 through 5 and G7 through 9. And then I'm going to wrap up the day by discussing next steps, including anticipated program launch dates. So just a little bit about us. We've been in the business for over 25 years. Our initial focus was on the testing and evaluation of IT security products, applications, devices, and other solutions. And we were actually the first commercial lab globally to receive ISO 17025 accreditation for information security testing. And we have continued that tradition in the health IT space. So we currently have involvement in the ONC Health IT certification program. We are the only test lab for the Concert by HIMSS program. We're also the only U.S.-based lab for the IG International Conformity Assessment program, as well as the only lab for the CDC immunization program, which we are running in conjunction with HIMSS and CNI Advantage. Just a little bit about our international accreditation. So we have ISO 9001 registration for our quality management systems. We're ISO 17065 accredited as a certification body by ANSI, and then we also have the test lab accreditation by NAVLab for ISO 17025 standards. And of course, we're authorized by the ONC for their certification and testing program. So those of you who have made it to some of our prior webinars, this slide is going to be really familiar to you. So these are the core categories. There are 60 total criteria in the 2015 edition program. And today we're going to be focusing on 6 out of the 9 design and performance criteria. We discussed the other 3 during our previous webinars, and you can always find access to those on our website if you review the recordings. So just a little bit about how the ONC defines criteria. So they have 3 main categories. So it's either unchanged, which means that the capabilities are the same or less of the same as certification criteria that existed in prior programs. There's also the revised category. So did we modify an existing capability requirement, or maybe we introduced a new capability that wasn't previously certified. And then finally, the ONC has the new criterion category. So, of course, this would be criteria that have never been tested before in prior programs.
Michelle, I'm sorry to interrupt, but your screen isn't updating the slides. I think you may have it paused.
I am so sorry. Can everyone see my slides now?
Yes.
Great, thank you. Okay, so now I'm going to dive into what those categories mean. So for the 6 criteria that we're looking at today. So 2 of them are revised, and that's our safety enhanced design, so usability testing criterion, as well as the quality management system criterion. And Kevin's going to go through with you what those changes are from the 2014 edition program to the 2015 edition program. We then have 4 brand new criteria. So 3 of them, G7 through 9, are those API criteria. And then we have a new criterion called accessibility centered design. And similar to the quality management system criterion, this is it's sort of the base criterion requirement for any certification. So anytime you want some level of 2015 edition certification, you must, at a minimum, certified to criteria G4 and G5. And again, Kevin will walk through what the requirements are for that particular criterion. It is attestation only, similar to G4 quality management system. Okay, next I would like to go ahead and introduce Kevin. Kevin is our certification body manager, and he will be walking through the specific certification test requirements for these 6 criteria. So Kevin?
Thank you, Michelle. Go ahead, next slide, please. So the first one we're going to talk about is G3, Safety Enhanced Design. Those of you who have tested under 2014 will probably be very familiar with a lot of the basic requirements for this criterion. They're very similar to 2014, but there's been a lot of changes to the nuances and the details in terms of what's required. So previously, there were several criteria that were applicable for safety enhanced design. So if you were testing any of A1 through 2, 6 through 8, and so on, as you see there on the screen, A16, A18 through 20, B3 through 4, or B9, you needed to do safety enhanced design. And you'll notice that many, if not all of those, either focused on medications or had something to do with medications. The goal of this criterion is really about patient safety and, of course, making sure that the right medications are prescribed. The testing itself was summative usability testing performed by the developer yourselves. We, as the ATL, the test lab, did not perform the testing for you. You could use a third party. There are some organizations that do usability testing for you that you could hire, or if you were a partner with another company who, say, like an e-prescribing vendor, you could always use their usability report. But the testing was done by yourself, and the results of that was submitted to us, and we reviewed that along with other attestation materials. We did not do the testing ourselves. The information was to be submitted via the NISTR 7742 report template. And if you remember, there was no minimum usability score required and no minimum number of test participants. Well, for 2015, some of the changes are they've incorporated some additional criteria. The criteria lists have changed, so it's not a direct one-to-one mapping, of course, as you're well aware. They still mostly focus on medications, but there are some other ones that don't. One of the first significant changes that you'll see is that in the past, when you attested to the safety enhanced design standard that you use, there was some flexibility there. Now it's a matter of you must use an industry standard or government approved user-centered design process, or else you must be able to submit documentation mapping the process you use to one of those standards. They're going to be a little more strict on that. The testing will still be a summative usability test done by yourselves or, as we stated, a third party. We will not be doing the testing ourselves. There's still no minimum usability score required, and you'll still be using the NISTR 7742 report template. However, in the past, there were certain fields within that report template that there's a little more variability in terms of how you reported those results. So things like how the scores were listed, maybe you submitted your results in just percentages, or you said 8 out of 10. Now that they're looking for is if the sample table in the report template says standard deviations, you must provide those results in standard deviations. It says if those results are provided in percentages, you must provide those results in percentages. So you'll want to make sure that you're familiar with how to calculate the different results of the standard deviations, and that you include those. Things like the test environment details, there's a note in there about the type of input. There was a little bit of variability in how much detail we accepted there. Now you're going to need to be very specific with those types of details. And anywhere you see a gray box or a table in that report template, you're going to need to make sure that you capture all of the identified information. Then the participant and task data will not only be captured in the report, which itself will be made publicly available through the Chapel website, but you'll also need to submit that as discrete data, which will be captured on the Chapel. So while participant names and, identifiable information won't be captured, information such as, their age, their gender, their professional work experience, all of that will be listed on the Chapel. The intent is to make the data searchable and downloadable, and that applies, again, both to participant data and the task data. Now, one of the biggest changes that I want to talk about is previously there was no minimum number of test participants. they're now saying a minimum of 10 test participants is required. That is not 10 test participants across the board necessarily. So if you were testing 10 criteria, you wouldn't want to have one participant each test one criteria. For each criterion that you're testing for usability, you'll need to have a minimum of 10 participants. Now, some of you may know you might have invited 10 participants in the past and only had 8 show up or 9 show up. So as you're scheduling your usability testing, you're going to need to make sure that you're prepared for the potential problem of either participants not showing on the day that they're scheduled to test, or for any reason the results that they accumulate may not be valid. So the 10 is the minimum. It's not enough to necessarily just invite 10. You'll need to have the results of 10 participants for each criterion that you're evaluating. Another significant change that you're going to see is now quarterly updates provided to the ACB. So any changes that you make to the interface that are applicable to any of the relevant criteria, no matter how minor, if you make a change, say, to your e-prescribing interface, it might just be where things are arranged on the screen, you would need to report that to the ACB. Now, any changes that you make are supposed to be reported immediately. At a minimum, though, you will need to provide a quarterly update with a list of any changes you made, including if no changes were made that might impact usability to the interface. You would still need to provide that quarterly update and just note that no changes were made. So let's see here. So next slide, please. Now, quality management system, again, if you've tested them in 2014, you're probably familiar with this one. Previously, it was attestation only, is what I refer to as a full disclosure requirement. There was no minimum standard required. You could say that you use an industry standard QMS, or that you used a homegrown or modified QMS, or maybe you use no QMS at all. All of those were acceptable. The intent of the criterion was only to make sure that the results were disclosed to end users. Now for 2015, they've actually changed that now. The QMS is required. That QMS must be based on a standard that's been established either by the federal government or a standards developing organization, or again, you would have to map it to one. In the past, there were organizations, developers who submitted an agile software development methodology as a QMS. You may be familiar with terms like Scrum method and so on. That is still allowed as long as you're able to map that to one of the standards. We have seen examples where agile software development methods have been mapped to the ISO 9001 process. So you would need to map it yourselves or find one of those documents explaining how it's mapped. So those are still allowed, but they do need to be mapped back to one of the standards. Now the response, just like before, will still be posted to Chapel. But again, it is no longer acceptable to say no QMS used. You must use a QMS in the development of your quality management system. Next slide, please. Now, accessibility-centered design, as Michelle mentioned earlier, this is a new one. It's similar in a lot of ways to the way QMS was constructed for 2014. So I meant to mention earlier, if you look on the upper right-hand corner, you'll see the red stop sign emblem with the word all in it. Both QMS and accessibility-centered design are applicable to all criteria. So any certification under 2015, you'll need to demonstrate both G4 and G5. But again, kind of like the 2014 version of QMS, for accessibility-centered design, it's attestation only. It is a full disclosure requirement. And you can attest that you use an accessibility-centered design standard or law, or you can attest that none was used. Either answer is acceptable, and then the response will be posted to Chapel. Now, if multiple standards are used, or if, say, maybe you only use accessibility-centered design for some criteria and not others, or maybe you use different accessibility-centered designs for different components, then you would need to specify that accordingly. An example might be, and you could run into this with both safety enhanced design and QMS as well. Examples might be you've partnered with a vendor who provides your patient portal, or you've partnered with a vendor who provides e-prescribing services. Maybe you need to include information about their QMS, their accessibility center design, and so on. And it's the kind of thing that the ATLs and ACBs are explicitly going to be on the lookout for, is if we notice that you're using a third-party portal or e-prescribing vendor, we're going to be looking at your safety enhanced design documentation, possibly your QMS documentation, your accessibility center design documentation, to see if you're accounting for those changes. So as you're thinking about putting this information together, please do keep that in mind. Now, one of the things that ONC has been very clear about with regard to accessibility center design, just because for the meaningful use program, I realize it's not the correct name for it anymore, just because it's not required for certification to use an accessibility center design standard, that does not mean that it exempts you from other applicable federal, state, or local laws or other regulations. So if in your state, or if there's an accessibility legislation and regulations, or maybe with one of your customers requires it for some reason, you would still need to adhere to whatever standards that they have. However, it's not something that's going to be required for meaningful use. All right, next slide, please. So now we're going to talk about the API criteria. Next slide, please. Now, there's a lot of overlap between the requirements for these, so I've broken out the slides a little bit differently. When you're testing the API criteria, if you notice in the upper right-hand corner, the green box essentially indicates that if you're doing any API criteria, you'll have to do QMS and accessibility center design. These all three are new, and if you're doing API, D1, D9, D2, or D10 are required. So D1 and D9 will both be required, and then you will need to do either D2 or D10. D9 is a trusted connection requirement. Essentially what that means is the connection between your system and the third-party system that's making the API request will need to have a secure connection. And we discussed trusted connection in a previous presentation. If you're not familiar with that one, I would encourage you to go back, watch the webinar, and review the slides. But there's a lot of detail regarding how the trusted connection occurs. So for 2015, there's 3 API criteria. The first one is G7, which is essentially receive a request to uniquely identify a patient and then return some sort of ID or token. Now, this one is sort of the precursor for the 2 that follow, because the intent here is that a system can say, hey, I need information on John Doe. Now, obviously, there will be more information that will be required in order to uniquely identify a lot of patients, because, duplicate names and whatnot. But if they provide enough information to allow you to uniquely identify a patient, then you're going to return that either patient ID or some sort of a token. That token then will be used for the G8 and G9 tests, and that's sort of the connection between them. Now, for G8, what you're going to be testing is the ability to respond to requests for patient data for the individual categories specified in the Common Clinical Data Set, and to provide those results in what's known as a computable format. In G9, you're going to be requesting that that data be presented collectively in a single CCDA document. So whereas G8, you might say, okay, I want to know the patient's medication list, or I want to know the patient's demographics. Where in G9, you say, I want the record for patient John Doe, and you should get the complete patient record in CCDA format. Next slide, please. Now, there's a lot of different details I want to go over here to kind of help paint this picture for you. The first thing I want to talk about is there is no specific API standard defined. There's not going to be a specific example of, okay, you need to provide, well, I have it there on the right-hand side, like the FHIR, the Fast Healthcare Interoperability Resources Specification. There's nothing that says you have to do that. So What you are going to be demonstrating, though, is rather than a standard, you're going to be demonstrating that you can respond to the request with the expected data according to the specified standards for content. So if somebody's asking for the medication list, you're going to need to include the RX norm codes. If they're asking for, problem information, diagnostic information, demographics, whatever, you're going to need to provide that data with the appropriate code set attached. Now, in addition to what you're demonstrating, a large part of the API criteria is going to be part of our attestation review as well. And you're going to be asked to provide a good deal of documentation. Now, some of that documentation, and you can find more information, I didn't have space to list it all here, so you can look at the CCGs or the test procedures themselves. So documentation would include information on how to use the API, such as API syntax, parameters, exceptions, and so on. So you'll need to provide that information to us. And you're also going to need to provide software components and configurations that are required for the other systems to be able to interact with your system. That could be network level connectivity information. It could be application level connectivity information. And last would be the terms of use to interact with the API. Now, all of that documentation will not only need to be submitted to your ATL or ACB for certification, all that documentation must also be publicly available on the internet from a publicly accessible hyperlink. So providing documentation in written format to us would not meet the requirement. You're going to need to have a URL that maybe it's linked to from your company's homepage or provided in some sort of other page where other users can find that information. Now, as I started to get into a moment ago, there are no standards required. However, they do recommend the FHIR spec, which is, I guess, pronounced FHIR. They do recommend that, again, that is known as the Fast Healthcare Interoperability Resources Specification. They do recommend that you use that. They recommend dynamic registration and security best practices. Now, some of this terminology could be perceived as being vague. Security best practices, for example, doesn't tell you what the security best practices are, but the intent is that when you're putting this information together and you're developing these systems, if you're not developed it already, that you're taking these things into consideration. So the security criteria required for demonstration to this, to the API criteria, the functionality required as it relates to security, or as I mentioned before, D1 and D9, so authentication and trusted connection, and in D2 or D10, which has to do with audit logging. But there are other aspects of security that you may want to consider. Consulting with experts in the industry, if you don't have any on your staff, would be a good way to go about that. At this point, it's probably good to point out that much like QMS, they are looking at expanding some of these requirements in the next iteration of criteria, which is probably a few years down the road. But they are looking to possibly incorporate standards at that time. And so I think if you look at the CCGs and the test procedures, you'll kind of see what direction they're headed, such as the FHIR specification. One of the most probably important things from a testing perspective that we can talk about here is that testing must be demonstrated using a separate system. So if you have, let's say, Acme EHR, you would not be permitted to test the API criteria with two identical EHR systems that were developed by you exchanging information. However, you are permitted to use an internal system. Whether you have an internal test tool or test harness that you use for development purposes, maybe an application that you receive from a third party or even a third party tool, any one of those would be permitted in order to demonstrate these criteria, but it can't be the exact same EHR. It's got to be some sort of a test tool or test harness or something like that. Something that is not explicitly bundled as part of the certified EHR technology. So you will, of course, need to include something that is under your own control. So when you're demonstrating, you're going to need to demonstrate both sides of the connection. So you will need to have access to the test harness or test system that you're using, as well as, of course, your EHR that you're having tested. Now, in addition to the other things we talked about regarding providing the results in XML format or computable format, they also want the ability to request the data by date as well as by date range. So you might say, I need the records for patient John Doe on March 31st, or you might say, I want the patient records on John Doe covering January 1st to March 31st. You'll need to demonstrate each of those as well as the complete patient record. And as I mentioned previously, the connection must be demonstrated via a trusted connection, which is then defined in D9. Okay, next slide, please. All right, so Michelle's going to talk a little bit about next steps, including projected launch date, and then we'll begin our Q&A session.
Great, thanks so much, Kevin. So just a reminder, if you do have any questions, make sure you submit those to us using the chat feature. I know a couple of people have submitted questions so far, so thank you for those. Please make sure you get those in within the next few minutes so we can address them. So on to next steps. So this is a launch timetable. So the first thing that I'm going to talk about is our prep packet. So we do have a prep packet available. It includes our customized test script, including links to guidance materials, sample test data. You'll likely note that the ONC did not really provide any test data for criteria that don't use some of the test tools. So we've created some mock data for you to use. You'll have access to that. We've provided you with instructions on where to find all of the sample files, as well as information on how to visually validate your files. There is quite a bit fewer elements that have to be reviewed during the visual validation of things like XML files, HL7 messages, but there is still some required, and so we provided you with guidance on that. So if you're interested in purchasing the prep packet, you can reach me via email, and we'll have our contact information up on the last slide, and I can get you in touch with our sales team so they can walk you through what that process looks like. And then as far as the program launch goes, so we spoke with the ONC earlier this week, and we're still anticipating that the program launch will be no later than March 31st. However, if we receive our scope extensions from our accrediting agencies, so NAVLAP and ANSI, if we receive those sooner, we will launch sooner. But just know that we're still anticipating no later than next Thursday. If you are interested in receiving information about how to register and apply for the program as soon as it launches, again, please contact me and I'll be happy to put you on a list to receive that information. This slide is just some resources for you on where to access the final rule, the test procedures and companion guides, the test tools, and so we just felt like this would be helpful information for you. And again, this slide deck as well as the recording will be posted online at our website no later than next week. And once it's available, we will send an email out to all of the applicants so that you're aware of where to locate that information. Okay, so next we are going to start with some questions. So Kevin, the first question is related to G4 quality management system. And the question is, if a formal quality management system is not fully in place, will it be enough to show adoption over time from release to release?
It's an interesting question. I think what we're going to see here is that, I think ONC had something of an expectation that the 2014 requirements were to encourage people to begin the adoption of the QMS, but obviously that wasn't necessarily a requirement, so not every EHR developer would have done so. At the time, the key is going to be what QMS system do you have in place at the time that you're applying for certification. So if something was in the works, I don't think we need to get into a lot of detail regarding when it was implemented and to what degree it was implemented. But at the time that certification occurs, we want to know that a qualified QMS system is being implemented at that point. But we're not going to go back and say, well, you're on version 7 of your EHR, and, you only started using this in the past 6 months, and, what we're using 3 years ago, certainly that's not what we're looking for. The intent is that the QMS being used at the time that you apply for certification meets the requirements.
Great, thanks, Kevin. The next question is on criterion G9. Do we have to build some sort of a queue to add requests from all patients and process that queue all at one time to create CCDA files, as well as the ability to send to the patient portal?
So sending to the patient portal with the API criterion, it would be more of a request response. So I may not fully understand the context of the question here, but you'll want to make sure that you can provide the data available upon request. I don't necessarily think a queue would be a way to meet this criterion. Just making a quick pass through the criteria requirements now, I don't see anything explicit about the time to respond. But if by queue you're talking about, once a day running a batch process to provide the results, I do not believe that that would be consistent with what the ONC is expecting here. I think they're anticipating more of an on-demand request. Now, on-demand becomes kind of a relative thing when you start talking about maybe you have a batch process that runs every 60 seconds or every 5 minutes. And if that's the case, it probably would be a matter of what we're able to observe during testing. We can follow up with JIRA certainly, or follow up with ONC certainly to determine if they do have a specific expectation in terms of the response time. But again, my expectation is just more of an on-demand request and response. As far as sending to the patient portal, again, because it's a request response, when the request is made, I believe you need to provide those results. If it's to a portal, you'll need to provide it then. I'm not sure if that part of the question refers to like an out-of-band sending of a portal. It would be in direct response to the API request. If my answer isn't clear, or maybe I didn't understand the question fully, please submit a follow-up question to Michelle.
Okay, great. And so the next question I'll go ahead and take is, if we were previously certified on GAP-eligible criteria, but the associated safety-enhanced design did not meet the current requirements for 10 participants, is the criterion still GAP-eligible? So a little bit of clarification around GAP eligibility. So for example, criterion A1 for CPOE, for example, may be GAP eligible. However, that criterion is GAP eligible, not G3 safety enhanced design. So it's important to separate those two. So G3 safety enhanced design certainly requires you to perform usability testing on some criteria that may or may not be GAP eligible. So it's important that we just separate those out. You will need to do usability design according to the new requirements that have been put forth by the ONC. Okay, so next, Kevin, I'm going to turn it back to you, and this is a question about criterion G8. Each individual CCDS category is unclear, and we have asked the ONC for clarity. What's unclear is if CCDS category is patient, including name, administrative sex, date of birth, et cetera, whether it's the data category of the API standard, for example, FHIR care plan, including goals, concerns, and assessment and plan, or the CCDS numbered items where date of birth is numbered individually. So it kind of goes on in that vein, but I think that's enough information for you to answer the question.
Yeah, so I think the issue here, it's actually good that you asked ONC for clarity, and we'll probably follow up with them as well. I think that's a great question. We've been working on the understanding that the category is based on the categories as defined by ONC in the CCG and test procedures. So they do define it as patient name as a single field, sex and date of birth and race are all individual fields. That was our understanding. But looking back over it now, definitely there's a possibility for a different interpretation, I think. Since you'll be providing documentation outlining how to provide that information, I think if asking for patient name provides a chunk of data that includes the sex, date of birth, race, and so on, maybe the complete suite of demographic information, if that's spelled out accordingly in the required documentation, it's quite possible that would be acceptable. So we will need to follow up with ONC on that for clarification, but we've been working on the understanding that they were referring to the individual categories as defined by the Common Clinical Data Set.
Right, and just to chip in, I agree with that interpretation, Kevin. We've actually submitted some clarification questions to the ONC about that particular test procedure. They had forgotten to include sex as the data category, and they are updating the test procedure to include that. So again, just affirming that the data categories they're referencing are the CCDS items. So I hope that helps. And then a follow-up to that question, Kevin, is that the ONC agreed in a telecom, but has not updated their specifications that query by date/date range may not make sense in all cases, and it's up to the vendor to include what they feel should be returned and be tested against that. So for example, a query for active medications by date or date range may not make sense and may be misleading for patients. So a vendor may choose to return only active medications as of today, for example, versus some snapshot of activeness in some prior period of time. So the question is, do we have any additional guidance on that?
We do not have additional guidance at that time, or at this time. They have alluded to, maybe some flexibility there, but my understanding is that some of that's going to be at the discretion of the ATL or ACB to be able to determine if it is or is not applicable. So if you can make a case that it's not applicable, and again, as the question references, it's addressed in the documentation, it may be possible for the test lab or ACB to accept that. But we're talking about something of a gray area here, I think. It's not going to be a black and white, yes or no type of thing, like, oh, you don't always have to do date or date range. If you're granted an exception, you're going to need to provide a sufficient justification for it. That much I can say. But in terms of what will necessarily constitute a sufficient justification, we've not received any additional guidance at this time, and we'll probably, I believe the response is going to be kind of on a case-by-case basis.
Great, thanks so much, Kevin. And so the next question is, regarding everything covered today, is there any type of latitude for self-developers? And the person who asked that question, Kevin, may need a little bit more details about what you mean, but Kevin, I'll turn it over to you first.
Yeah, I think we are going to need some maybe specific examples of what you have in mind. I'm not aware of any specific, or at least none come to mind. They're still expecting, that you're using a quality management system and accessibility-centered design. They're still expecting safety-enhanced design, because even though you're self-developed, a lot of these aren't for the benefit of the provider, they're for the benefit of the patient. So, those three criteria in particular, and I'll talk about API in a moment. When you're talking about safety-enhanced design, quality management system, accessibility-centered design, it's really about patient safety. That's really what they're striving for there. So it doesn't matter if it's a self-certified product or not, because if it's still going to be used by a provider to provide patient care, they want to make sure that those safety concerns are being addressed through those criteria. Now, the API criteria, I am not aware of a particular case where there's any latitude granted to self-certified products or self-developers. I think the intent, or I'm sure the intent, I should say, is that there's a certain amount of interoperability. They really want to make sure that the ability to share data between disparate systems is there. Now, again, they haven't specified a particular API standard that has to be used, so it's not to say that everybody's going to automatically work with one another, but you do need to provide that documentation to allow another product. If there is some unique circumstance where you believe that it wouldn't apply to your system, I think what you're going to run into is, because the API criteria aren't necessarily required, like it's not like if you're doing transitions of care, you must do API. I don't know that you're going to run into a situation where you would necessarily need to be granted an exception. I may have to revisit that, but we don't I'm not aware of any explicit example that ONC is granted. So if you have a more concrete example that you want to provide, I might be able to address it more specifically.
Great, thanks, Kevin. So I'll go ahead and take the next question, and the question is, where can we find the acceptable standards for quality management systems? And so I can tell you where you can find the examples. So there were some QMS standards that were suggested in the ONC's final rule, and you can find the link to that specific reference as well as the call out of some of the standards. And keep in mind that these are just examples. It may not be a comprehensive list. You can find it in the G4 Certification Companion Guide, and you can find that on the ONC's website. It's their 2015 edition test methods, and so you would be looking for the G4 Certification Companion Guide. And I know that in your question you said specifically that yours maps to 21 CFR 820, and I can tell you that they specifically address that in the companion guide. They talk about the FDA's quality system regulation, and they do say that you need to make sure that you cite your compliance with FDA's quality system regulations for certification. They've provided another direct reference to the final rule, so definitely go to the certification companion guide and look that up, because I think that'll be very helpful to you. Next
and just
question,
to clarify,
yes.
I just wanted to add to what you're saying, and I just want to be very clear. It's not necessarily an exhaustive list in the certification companion guide, but there are some definite examples there. So just because your QMS system is not listed there doesn't necessarily mean that it's not acceptable. So.
Right, exactly. That's what I said. It's not a comprehensive list. However, this person's specific example is listed there. So they should definitely look at that. So Kevin, the next question is, where can we find a list? So does the ONC have an approved list of accessibility-centered design standards?
So they actually mentioned in the final rule, and they reference it in the CCG, that they will be working to provide additional guidance and identification of accessibility-centered design standards in the test procedure. Now, at this time, I don't believe that they've provided those yet. But it is something that they've been asked about ever since the proposed rule, the NPRM, and they have noted that they will be providing additional examples at some time. Unfortunately, we don't have control over that. We don't have any additional visibility into that at this time, but they are aware of and sensitive to that this is something that they need to provide. And unfortunately, that's the best answer I can provide at this time. It's a great question.
Great. And so the next question that I'll address is the 2015 edition yet approved for release? And so I can tell you that the final test procedures, tools, all of that is out there on the ONC's website. However, the test labs and certification bodies are not yet authorized to launch the program. However, we anticipate launching it no later than March 31st. That's the date that the ONC has provided us for launching. The only thing all of the ATLs and certification bodies are waiting for at this point is the scope expansions to be released by NAVLAP and ANSI. And so a scope expansion says you were authorized and competent to provide testing and certification of, the 2011 edition and the 2014 edition criteria. And so the scope expansion says we now deem that you are competent to perform certification testing for the 2015 edition program. So that's the last thing that we're waiting for, and we still anticipate having that by next Thursday. And those will be announced as a batch for all of the test labs and certification bodies. Okay, so next question, Kevin. How are the dates going to be checked for the API? So I think in the previous calls, the date range was raised as a patient safety concern, and the certification gives the impression that the dates would be governed by the technical documentation of the API. So if the documentation of the API says dates are not accepted for certain data elements, would that be acceptable?
So that one's going to be tough to answer because I think, again, this is going to come back to additional information regarding the justification. I don't think there's any blanket answer that we can give because it might be appropriate to say certain information is, not relevant or conducive to being by date or date range. But, looking at something such as what were the active medications on January 1st, I don't know why that would not be acceptable. I'd have to look at the justification and understand maybe the use case that they're specifically referring to. I believe that was one of the examples that was given. But I really think that the goal here is the expectation is that the data can be provided by date and by date range by default. And if there is an exception, it would have to be addressed individually on a case-by-case basis. I don't believe that just saying dates are not accepted for certain data elements, that's not a justification, that's just a statement. You need to justify why they're not available. And when you think about it in terms of what the certification criteria is doing, it's setting that minimum standard. So if you want an exception from that, you can't just say, I'm not going to abide by it. You need that, again, that justification.
Great, thanks, Kevin. And so I'm going to answer another question, and then I'll come back to you, Kevin. So the question is, can we certify with the 2014 edition program in August 2016? And I can only answer that question as of today's date. And so the answer would be yes, you can. Currently, the 2014 edition and the 2015 edition program are set to run concurrently until such time the ONC tells us to sunset that program. So as of right now, we have not been told we're shutting down the 2014 edition program. So you may test in August of 2016 so long as the ONC hasn't sunset the program by then. I don't anticipate that they will, but there's a lot of things up in the air regulatory-wise regarding the CMS and MACRA and the Certified EHR Technology definition, things like that. So if things should change in that regard, we'll certainly have a webinar and make sure everyone's informed about that. So Kevin, I wanted to come back to a question you had answered earlier. It was G8, and I'm just going to remind you of, what that, or sorry, criterion G9. And so that criterion question was, do we have to build some sort of a queue to add requests from all patients, process the queue, have some ability to send it to the patient portal? And so a follow-up on that was, the G9 test procedure says at one time, and so can you expand on your earlier response, specifically related to the requirement that it's the requests are at one time?
Okay, actually, Michelle, if you could possibly bring up slide 15 on the screen, it'll make it easier, I think, for me to respond.
Sure. Here we go.
So I think, just to clarify, so for G9, the response is going to be a document in CCDA format. I mean, if there's requests for multiple patients, and therefore you're providing multiple CCDA documents, certainly I think that would be acceptable. Though I think, we'd have to know more about the implementation, looking into documentation to see how the individual documents will be sorted by individual patients. But suffice it to say, when you make a request in G9, you're going to be sending all of the data in one CCDA document. So I would expect kind of a one-to-one mapping in the request and the response there. As far as the individual categories, I'm kind of anticipating the same thing where even though it's not just asking for the whole data set in one document, when I talk about in computable format, I'm still expecting that if somebody requests, demographics, they're going to receive demographics versus if they're going to request, problem lists, they're going to receive problem lists. So that, again, that's how I'm currently interpreting it. Hopefully that kind of helps clarify the answer. I'm not sure if it does, but yeah, I'm thinking more of a one request to one response for each request kind of thing.
Right. And Kevin, we have another question, and you did address it earlier, but I'm not sure if this individual was on and heard your answer. So it was regarding the acceptable accessibility center design standards, and her understanding was that the ONC was going to provide some guidance around those standards, and is that going to be provided? And I know you'd addressed it earlier, but I'm not sure this person was on the line at that point. So if you could go ahead and answer that again. Sure.
And it is a very good question, so it's probably worth addressing it again. So as far back as the final rule, ONC did, due to feedback they received from the NPRM, they did say that they would be addressing providing some additional acceptable standard examples in the test procedure. They put that in the final rule. They also referenced that in the CCG that was published a couple months ago. As of this time, though, I don't believe they've published those standards in the test procedure. And just so everybody's aware, ONC is either recently made or in the process of getting ready to make, some changes to the test procedures. That's why I say I'm pretty sure at this time, even if I look at the current one, that may not necessarily have that document to change tomorrow. But they've not published that information yet that I'm aware of. They are aware of it, they're sensitive to it, and they are promising they will be providing it. Unfortunately, I can't provide any sort of a concrete timeline or any additional information. We're sort of anxiously waiting for that information, maybe not quite as much, but almost as much as the developers are. So as that information is made available, we'll be updating our guidance materials and so on, but at this time, we don't really have a complete list either, or even a short list, really.
Great, thank you, Kevin. It looks like that concludes all of the questions we've received so far. We do have a few minutes left and could entertain a few more questions. What we'll do is just wait another 30 to 45 seconds or so. If you have a question, please go ahead and put it in the chat window. Otherwise, if we don't have any others come through, we'll go ahead and close the webinar.
And while we wait, Michelle, I can go ahead and just kind of state that, a lot of these questions, and even in some of our previous webinars, we weren't always able to provide answers immediately. I know some questions we reached out to ONC and got answers, and we were trying to communicate with the individual questioners to make sure they received that information. But a lot of these questions, as we move forward into the launch of the program and whatnot, knowing that there are concerns of some of our customers and whatnot, we will be providing a lot of updates to our guidance material. So whether we're updating the test procedure based on the answer provided by ONC, or maybe even an attestation form, we'll at least be updating our guidance material. So if you are purchasing a prep packet, or if you do purchase it in the future, or test scripts in the future, and you still have some of these questions, by all means, check our guidance materials. And if you're still not finding those kind of answers, we'll do what we can to get those answers to you at that time. But with some of this still in flux, getting final confirmation from ONC, there's just certain answers we can't provide just yet.
Great. And so we did have a couple more questions come in, and I'll go ahead and take those. So the first one is, am I correct that if we purchase the prep packet, we would need to test within 6 months? And the answer to that is no. We do have a provision right now that if you purchase the prep packet now, if you return and sign a full testing contract for the 2015 edition program within 6 months, then you can apply the cost of the prep packet to that testing engagement. So it's not that you have to test within 6 months. You simply have to come back and sign a contract for testing services within 6 months. So I hope that helps clarify. Also, the question is certifying the 2015 over the 2014 edition program. So is the advantage to using the 2015 edition program for certification is that it will lead us more smoothly into Meaningful Use 3. And so what I can tell you is that we have a lot more details on our website. We have an FAQ page devoted just to the 2015 edition program, so I would recommend you check that out. But just sort of in a nutshell, what I would say is that remember that as it currently stands, so the latest CMS final rule that still covers meaningful use in the stages 1, 2, 3, and so on. So providers who are entering stage 3 of meaningful use must use 2015 edition certified software. Now, many of them likely won't be entering that phase until 2018, but if some of them may be ready in 2017. So it's probably a good rule of thumb for you to survey your clients, find out when they're going to be hitting stage 3, and making sure your system is certified to the 2015 edition program before that. Okay, so then the next question is, can you speak to the concept of a complete EHR? So are all criteria required, or are criteria pass, fail, not tested? And so remember, in the 2015 edition program, there is no concept of a complete EHR anymore, right? So there's no, ambulatory complete EHR designation versus an inpatient modular EHR certification designation. In the 2015 edition program, you are only going to have certification as a health IT module, regardless of the number of criteria that you've certified to, whether you've certified to 1 or 60 it doesn't matter. There's also no longer a certification designation tied to a domain, so ambulatory versus inpatient. You will be Health IT Module certified. There are, however, some criteria that have domain-specific requirements. So, for example, in demographics, there are 2 or 3 data elements that are specific to the inpatient domain only. So if your system chooses to comply with those inpatient or ambulatory specific requirements, just know that those will be tracked by the test lab, and they will, for the most part, be reported discreetly on the ONC's new Open Chapel website. Okay, so then the next question, Kevin, is for you. And this is a person who says they have a question about their product updates. So we release a new product, a new update, every 13 weeks and submit product updates on each release. Are we going to be scrutinized for that frequency under the new transparency requirement?
So just to be clear, we are finalizing an FAQ that we'll be publishing to our website. This question will actually be a part of the FAQ. What I can tell you, I can go ahead and tell you, is that as an ACB, we are required to assess whether products have been certified. The products that have been certified continue to conform to the requirements of certification once implemented in the field. Now, per ONC, that surveillance should be required upon the issuance of 3 or more inherited certified status requests. Now, that does not mean that products will automatically be retested as part of surveillance. However, it does provide a mechanism by which we as the ACB can carry out various surveillance activities, wait for surveillance activities, or initiate triggers to conduct further surveillance. The inheritance requests themselves require that the product developer has kept, the ACB apprised of all the changes to the product, regardless of the number of inheritance requests. And, the scope of the changes to the product will also be factored in. So, while it's not like you're going to be targeted because of frequent requests, it is a kind of thing where, somebody who's requested inheritance, one time, it's probably less likely, and nothing's written in stone, but we're talking about likelihood here. It's less likely that drastic changes have been made. If somebody's revising a product every month and they're requesting inheritance every time, there's a certain amount of due diligence that's expected to go back and make sure that during those 12 updates over the course of the year that in fact nothing did change. Now, the surveillance requirements are very much defined by ONC, and we're required to follow them. So kind of getting back to the first part of the answer, yes, that does weight the likelihood of somebody being selected for surveillance, but it's not an automatic trigger per se. And when the FAQ gets posted, you'll be able to read a little bit about that. And of course, you can always follow up with your ACB for further clarification or concerns.
Great, thanks so much, Kevin. And that concludes our webinar today. Thank you so much for joining us. We will have this recording and the slide deck on our website by next week, and everyone will get a quick email notification once that's been done. Just thank you so much for your attendance and for your participation in our entire 2015 edition webinar series. If you do have any additional questions, please direct those to us. You can find our contact information on the screen here. Any testing related questions, go ahead and send those to me. Any certification questions, go ahead and send those to Kevin. Thanks so much, and have a great rest of your afternoon.
Thanks, everyone.